Good afternoon, and welcome to the National Center for Primary Care Tobacco Webinar Series. This is the second part of a three-part series on treating patients with mental health conditions who use tobacco. My name is Richard A. Gooden. I'm the Director of Communications here at the National Center for Primary Care, and we're expecting a lively and engaging discussion with three authorities in the field of both primary care and behavioral health. To follow us on Twitter, you could follow us at PriCareMatters. You could also visit our website at www.primarycarematters.org. This webinar is being done in partnership with the CDC as part of their TIPS campaign, and also in partnership with the American Psychological Association. A little bit of housekeeping. The American Psychological Association has designated the live educational activity to receive 1.25 CE credits. So the credits will only be available for the live event. And following this webinar, all attendees will be emailed a post-evaluation. In order to receive the CE credits, the attendees must demonstrate a mastery, which means you'll have to get at least an 80 on the post-evaluation test. And there'll be no partial credits awarded. It's a little bit of housekeeping. Everyone's microphone will be on mute. So as you enter the room, your microphone will be muted. Refer any tech issues that you have while you're on to the directly to our tech support. We have a tech support tab in the lower right-hand corner. And then we also have a Q&A box in the lower left-hand corner. And then for the Q&A box, we encourage you to type your questions in throughout the presentation. We'll have different breaks for questions and answers. So we strongly encourage you to type your questions in throughout, and we'll be taking them. So we're looking to make sure that this is a very engaging and enlightening presentation. And we will also be taking questions at the conclusion. I would be opening this up to Dr. Nadine Caslow, who is a professor, vice chair for faculty development in the Department of Psychiatry and Behavioral Science at Emory University School of Medicine. Dr. Caslow?
Greetings, and I hope that everyone can hear me, since I see that there's a lot of chatter on people saying that they couldn't hear you. So,
I hear you clearly.
But there's a lot of people on the chat list saying that they can't hear or that it's not clear. So I hope that, oh, now they're saying it's good. Okay, well, hopefully it'll stay good. So greetings. My name is Dr. Nadine Caslow, and I'm the past president of the American Psychological Association. On behalf of myself, Dr. Susan McDaniel, our current president, who is in England right now, and the APA, I want to say how excited we are about today's program. It fits with our focus on health equity, integrated care, and disease prevention and promotion. At the APA, we are committed to working with our partners to stamp out smoking. As you mentioned, today's effort, treating patients with mental health conditions who use tobacco, is a partnership between the Morehouse School of Medicine, the Centers for Disease Control and Prevention, and the APA. APA has a health disparities program, and its purpose is to increase support for research, training, public education, and interventions that reduce health disparities and promote health equity among underserved and marginalized populations. This program, which is housed in our Public Interest Directorate, recognizes the disproportionate impact of smoking on many health priority populations, which includes individuals with mental health problems, racial ethnic minority groups, people living with HIV/AIDS, and the LGBT populations. We are excited that we will soon be launching a free app for professionals on smoking in health priority populations. Smoking is a leading cause of preventable death, and it is something that all healthcare providers can and must attend to. I am confident that our distinguished speakers today will educate all of us about effective ways to move this agenda forward. We look forward to collaborating with them and everyone on this webinar on this ambitious agenda. I would now like to introduce our two distinguished speakers for today. For most of us, Dr. Satcher is a legend in his own right and thus needs no introduction. However, a brief introduction is warranted. David Satcher, MD, PhD, is founding director and senior advisor of the Satcher Health Leadership Institute at the Morehouse School of Medicine in Atlanta, Georgia. The mission of the Institute is to develop a diverse group of public health leaders, foster and support leadership strategies, and influence policies towards the reduction and ultimate elimination of disparities in health. The Institute's programs reflect Dr. Satcher's experience in improving public health policy and his commitment to eliminating health disparities for underserved groups such as minorities and the poor, and shedding light on neglected issues such as mental and sexual health. Dr. Satcher was sworn in as the 16th Surgeon General of the United States in February 1998, and he served in this role until 2002. He also served as the 10th Assistant Secretary for Health in the Department of Health and Human Services, making him only the second person in history to have held both positions simultaneously. His tenure to public service also includes serving as the Director for the Centers for Disease Control and Prevention and Administrator of the Toxic Substances and Disease Registry from 1993 to 1998. He was the first person to have served as Director of the CDC and to have been Surgeon General of the United States. Dr. Satcher presently occupies the Poussaint-Satcher-Cosby Chair in Mental Health at the Morehouse School of Medicine. This recognizes his long-standing commitment to removing the stigma attached to mental illness, as evidenced by Mental Health, a report of the Surgeon General, the first Surgeon General's report that was released on mental health during his tenure as Surgeon General. As Surgeon General and Assistant Secretary for Health, Dr. Satcher led the department's effort to eliminate racial and ethnic disparities in health, an initiative that was incorporated as one of the two major goals of Healthy People 2010. In 2005, he was appointed to serve on the World Health Organization's Commission on Social Determinants of Health. Dr. Satcher has received over 50 honorary degrees and numerous distinguished honors, including top awards from the National Medical Association, the American Medical Association, the American Academy of Family Physicians, and the American Academy of Family Physicians. He also received the Ronald Davis Special Recognition Award from the American College of Preventive Medicine and the Symbol of Hope Award for Health Promotion and Disease Prevention. He received the Benjamin E. Mays Trailblazer Award and the Jimmy and Rosalind Carter Award for Humanitarian Contributions to the Health of Humankind from the National Foundation for Infectious Diseases. Dr. Satcher is a member of Alpha Omega Alpha Honor Society and a fellow of the American Academy of Family Physicians, the American College of Preventive Medicine, and the American College of Physicians. He is a member of the Institute of Medicine, National Academy of Sciences, the 100 Black Men of Atlanta, and the American Academy of Arts and Sciences. A proponent of healthy lifestyles through physical activity and good nutrition, Dr. Satcher is an avid runner, rower, and gardener. Our other presenter today is Dr. Timothy P. Carmody, PhD, who is the Director of Health Psychology, Mental Health Service at the San Francisco VA Medical Center Health Services, and a clinical professor of psychiatry at the University of California, San Francisco. Dr. Carmody has two areas of research: treatment of tobacco use and management of chronic pain, both of which are vital to the health of our nation, including our veterans. He is a nationally recognized leader in smoking cessation research and has been involved in several studies investigating various combinations of medications and behavioral counseling in the treatment of nicotine addiction. Dr. Carmody's smoking cessation research has focused on alternative and innovative interventions that are designed to help ex-smokers to maintain abstinence, including the use of text messaging, hypnosis, and contingency management programs. Dr. Carmody has also been involved in the development of tobacco use cessation interventions for smokers with substance use disorders in early recovery. In the area of pain management, he has conducted studies on the efficacy of face-to-face and telephone-delivered cognitive behavior therapy for veterans who suffer from chronic pain. Now let me turn it over to our two best speakers and enjoy this webinar. Thank you very much.
Well, thank you, Dr. Kaslow. I'm delighted to join you and Dr. Carmody in this very important webinar dealing with treating patients with mental health conditions who are addicted to tobacco. My objectives are to review the Surgeon General's reports on smoking and health and the global progress since that time. I also want to talk a little bit about mental illness. As you pointed out, we released 3 reports on mental health and mental illness, as well as 3 reports on smoking and health. So I want to discuss the major messages of those reports. Also, the implications of the Affordable Care Act for access to care for the treatment of mental disorders and how that impacts this subject. And finally, to describe the relationship between physical activity and mental health and why integrated care is critical for smoking cessation in patients with mental disorders. Well, I will not repeat the mission of our institute, but just to say that we have tried very hard to maintain the momentum in this area dealing with health equity, not just on a national basis, but also the global area. The whole issue of leadership in areas such as this is critical, and I think it was the Institute of Medicine's report in 1988 on public health, the future of public health, where it was stated that today the need for leaders is too great to leave their emergence to chance alone. We believe that, and that's the basis for our programs. Now, in 1964, we had the first actual report from the Office of the Surgeon General. Prior to that, Surgeon General had been primarily the chief administrator of the Public Health Service. But in 1964, we had the first report, and that report was on smoking and health. And I'm only pointing that out to say that in the 50 years between 1964 and 2014, there were some major developments. And I think the most important one was this leading cause of death in the country, smoking, was impacted significantly. And whereas there were about 43% of the American people who were smokers in 1964, about 2014, that figure was down to less than 20%. And today, of course, it's around 16%. However, the importance of today is that smoking has always, given the time since we've had data, been a more serious problem for persons with mental disorders than others. And even today, when we've made so much progress, it continues to be a much greater challenge for people with mental disorders. These are reports that we release, and there are 2 here dealing with smoking and health, and those are women and smoking and reducing tobacco use, which we released at the World Conference on Tobacco in Chicago in 2000. But the next slide shows our projections that were actually made in the mid-90s about deaths worldwide from tobacco. And as you can see, it was estimated that deaths from tobacco would increase dramatically globally through 2030. The good news is that it is highly likely that there will be far fewer deaths from smoking than projected here, because in 2004, I believe, the World Health Organization held its first treaty, and that treaty dealt with tobacco. And 150 countries signed on to that treaty, and that treaty included interventions that were very similar to what we had implemented here in terms of not allowing the advertising of smoking, of tobacco on TV, making it illegal to sell tobacco to children. Several things that have been proven to reduce smoking came out of the World Health Organization's Treaty on Smoking and Health. And already we're seeing the impact of that in developing countries where smoking had been going up dramatically. So even though smoking is still a major problem and still the leading cause of death in this country, still about 450,000 people a year dying from smoking, things are improving. We estimate that we have probably saved over 10 million lives in this country since the first Surgeon General's report on smoking and health. The next slide shows, well, this is a poll question, and I hope you are ready to respond. And I won't respond, but just give you a minute to look at it. Which comes first, tobacco addiction or mental illness? And we can talk about that later. Okay. I had the opportunity to release several reports on mental health. In the first report, which, as Dr. Caswell said, was the first ever Surgeon General's report on this topic, we defined mental health as the successful performance of mental functions, resulting in productive activities, fulfilling relationships with others, and the ability to adapt to change and successfully cope with adversity. And I mean, and if you accept that definition of mental health, then you can see why mental health would be so important to resisting tobacco or quitting if one was addicted to smoking. And the next slide shows how we define mental illness. And we define mental disorders as characterized by abnormalities in cognition, thinking, emotion, or mood, or the highest integrative aspects of behavior, such as the ability to be productive or to manage relationships with other people, beginning with family. So mental illness takes its toll in various ways in terms of how people are able to function in society, again, beginning within their families. We had several key messages, and I'll go through these rapidly. We said that mental health is fundamental to overall health and well-being. Mental disorders are real, because back in the time that we released this, there were still people who questioned the reality of mental disorders. Mental disorders are disabling. And in fact, mental disorders are as disabling as cancer or heart disease in terms of premature deaths and lost productivity. The life expectancy of persons with mental disorders average 25 years less than the rest of the population. Now my slide just went off. I hope yours didn't. But I'll keep talking until it comes back on. Yeah, my screen has just gone dark. But so if you ask the question, why do people with mental disorders have a life expectancy that's 25 years less than the rest of the population? Tobacco is one of those causes. In fact, people with mental disorders tend to die more frequently of chronic diseases, heart disease, cancer. So you can see how lifestyle, obesity is also, by the way, more common in persons with mental disorders. But you can begin to see, if you just look at the issue of smoking, if people with mental disorders are more likely to smoke and have more difficulty quitting, then that alone would explain why they have a lower life expectancy than the rest of the population, than the average life expectancy. Okay. Mental disorders are common, and I have to say, when we released our report in 1999, people were surprised that 1 in 5 Americans had a diagnosable mental disorder. And now, of course, we know that it's actually more than that. It's certainly 1 in 4 or even greater Americans who will suffer some mental disorder each year. That's over 45 million adults now and probably about 15 million children. So mental disorders are common. So when we talk about mental disorders and smoking, it is a challenge. Here's another poll question for you. Which do you believe has a greater stigma, tobacco use or mental illness? And I must say that in our report, we talked a lot about stigma and its impact upon the individual or the family, the society, and even on policymakers. And of course, that stigma is probably had a lot to do with the fact that it took so long to get parity of access to mental health services. Okay. Now, there was good news and bad news in the report on mental health. The good news was that because of ongoing research, we have improved our ability to recognize, diagnose, and treat conditions effectively. And that's very important for this topic. And Dr. Company, of course, works with that every day. But the fact that we now know that 80 to 90% of the time we can, in fact, treat mental disorders and return people to productive lives and positive relationships. And so what does that mean for being more successful at getting people to quit smoking? Of people with diagnosable mental disorders, unfortunately, and this was much worse in 1999 than hopefully it is today, but fewer than half of adults were getting any kind of help. And what really upsets me about this is that when you look at children, we were having a lot of difficulty, and we still are in getting treatment for children. We have a major deficit of child psychiatrists. And it's also, again, why it's so important for us to look at strategies like the integration of mental health in primary care. The stigma issue, as I said, if you look at how it impacts treatment, it impacts the individual with the mental disorder, it impacts the family, the community, and society, and the policy arena. Now, when we released our report, we were not talking a lot about post-traumatic stress disorder. But as more and more veterans have returned from Iraq and Afghanistan, this problem has really grown, and it continues to grow in terms of veterans, and that means the challenge of getting people who smoke to quit smoking has grown. If more persons who are smoking have mental disorders. So post-traumatic stress disorder in a population that tends to smoke more than the rest of the population becomes a major challenge. I thought this was important, and I remember this presentation, I think, was to the American Psychological Association in Chicago in 2010. But basically, this is due to work done by SAMHSA. And what it shows is that persons who reported having a mental disorder in the past year had a much greater problem with addictions of all kinds. You see the marijuana, illicit drugs, generally cocaine, inhalants, heroin, In each of these categories, persons with mental disorders were more likely to be addicted. And of course, here today, we're talking about the fact that they're more likely to be addicted to tobacco or nicotine, and therefore the challenge of providing treatment to that population. Well, I think there's some good news here in the Affordable Care Act. I think there are at least 3 ways the Affordable Care Act is increasing access to mental health and substance use disorder services. And again, I want to keep reminding you that sort of one of the major trends now is integrating mental health and primary care. And if you think about what that could mean to somebody with mental disorders and also addicted to tobacco. But the Affordable Care Act expands mental health and substance use disorder benefits and parity. In fact, mandates that that these services be covered by all insurance companies. Now, the bad news, of course, is that there are many states that have not agreed to expand Medicaid, for example, which could make a big difference for many people in this population. So we're still struggling with that. But the Affordable Care Act's intention was to fully implement the Mental Health Parity and Addiction Act. Most health plans must now cover preventive services like depression screening for adults and behavioral assessment for children at no cost. These preventive services, the Affordable Care Act tried to build in cost-saving programs that focus on prevention. And finally, starting in 2014, plans would not be able to deny coverage or charge more due to pre-existing health conditions, including mental disorders. And again, I have to say, when you think about children being diagnosed with mental disorders and the fact that most mental disorders have their own set before adulthood, the threat that it was to so many families when a diagnosis of a mental disorder was made, if that was going to be a basis for excluding that person or those persons from coverage. This just tells me that I'm getting close to the end here. And I just wanted to share with you increasingly good news about the relationship between behavior and behavioral disorders. In other words, we now know, of course, that physical activity has a very positive effect on depression, as well as some other certainly mood disorders generally. And so the same things that we've been talking about for preventing chronic diseases in general, we now know that they can have a very positive impact on mental illness. So that is good news. Now, this is the Surgeon General's prescription, which we released again in 1999, about lifestyle. And on this same prescription where we talk about the importance of regular physical activity, we point out the importance of avoiding illicit drugs and especially to becoming addicted to tobacco. So there's one thing to prevent this addiction, but also another thing to be committed to treating people who happen to experience that addiction. Okay. Well, this is my last slide. So in order to eliminate disparities in health, we need leaders who care enough, know enough, will do enough, and who will be persistent until the job is done. And I hope we're all committed to that. Thank you very much.
Thank you very much for a lively discussion. I understand I'm kind of low, so excuse me. Just to do a couple of follow-ups for our poll question, the initial one, what comes first, mental illness or tobacco use or tobacco addiction, excuse me. 72.8% of the respondents said mental illness, while 27.1% of the respondents said tobacco addiction. Also, the overall feel was that mental illness still carries a stronger stigma than tobacco use. Again, I strongly encourage you to write your questions or type your questions in the lower left-hand corner. And I am going to transition now to Dr. Timothy Carmody. Thank you.
All right, thank you very much. And thank you, Dr. Satcher, for that inspiring providing context for looking at tobacco use cessation in mental health condition populations. So the objectives of my presentation want to evaluate the behavioral health and neuroscience theories that are typically used in developing tobacco cessation interventions for individuals diagnosed with mental health conditions, discuss some of the barriers and facilitators to tobacco cessation in this population, examine methods for evaluating the health outcomes and monitoring individuals during their quit attempts and following their cessation, and then provide some examples of successful programs for best practices nationwide. So just a little bit about myself, my current involvement with tobacco use cessation. So I currently chair our technical advisory group for the Veterans Health Administration Tobacco and Health Program. And here in San Francisco provide oversight to our tobacco use cessation program, and including providing direct evidence-based interventions to our veterans in primary care and mental health programs, and providing consultation and training to staff in interprofessional training contexts, and assisting consumers in our psychosocial rehabilitation recovery program, veterans with serious mental illness, and assisting them in their efforts to quit smoking as part of their recovery plan, and also supervising trainees in a variety of professions providing tobacco use cessation services, both in mental health and in primary care settings, and then conducting research on tobacco cessation interventions. So here's our first poll question. What is the most common mental health condition you encounter in your healthcare setting? And there are 4 choices: depression, schizophrenia, bipolar disorder, or post-traumatic stress disorder. So I'll give you a few moments to answer that poll question, and then we can return to that question later and discuss your own healthcare settings and the most common mental health conditions that you encounter. A very important part of addressing tobacco use and facilitating smoking cessation in individuals with mental health disorders, mental health conditions, is to address the various myths about tobacco use and mental illness. And in this slide, there are 5 most common myths about tobacco use. And as you read through, number 1, tobacco is necessary self-medication for individuals with mental health conditions. And there are data, there are studies, there's evidence to help us to refute, to challenge these myths about tobacco use. The third myth, people with mental health conditions cannot quit smoking. And again, there's growing evidence for studies that have documented success in quitting in individuals with a variety of mental health conditions, including depression, schizophrenia, post-traumatic stress disorder, and substance use disorders. So it's a very important part of providing training and support to providers, mental health providers, overall healthcare providers in primary care, integrated care settings, and mental health, especially behavioral health settings, to understand and become familiar with the most recent evidence that really challenges these myths about tobacco use and mental illness. These are also important to address in providing direct in counseling our patients as well, who may also have these beliefs. And this slide summarizes data from a number of studies that examined the intention to quit smoking in the next 6 months. We call that contemplation stage of change. And then in the lighter colored part of the bar, intention to quit in the next 30 days, and we call that preparation for quitting. And the top bar is the general population of smokers. And in this slide, we compare intention to quit across different populations of mental health patients in outpatient settings, depressed outpatients, individuals with mental health conditions in inpatient settings. And what we see is that there's a comparability that smokers with mental health conditions or addictive disorders are just as ready to quit smoking as the general population of smokers. So they are, it makes it very important for us to consider making sure that we offer and provide the same access and opportunities for interventions that can help and assist these individuals to quit smoking. Another factor that comes out of these studies is there's no relationship between psychiatric symptom severity and readiness to quit. That even with more severe psychiatric symptoms, readiness to quit does occur. Now, some of the health behavior theories underlying our counseling interventions are interventions for nicotine dependence, theories that focus on health habit behavior change. These include stages of change that focus on self-efficacy for coping with the symptoms of mental health conditions, and social learning theory that address both the self-beliefs and social support and environmental support for the continuation of health-related behavior, both in a negative and positive way. Theories regarding the self-medication hypotheses around the use of tobacco and other substances as a way of medicating the symptoms of mental health conditions. The biopsychosocial model of nicotine dependence that includes both the social, environmental, and developmental aspects of the development of nicotine addiction, as well as the neuroscientific aspects of the role of nicotine in the brain. And then general theories regarding psychopathological vulnerability based on family history and early environmental exposure that increases vulnerability both to addictive behaviors and to mental health conditions. So an important aspect of nicotine dependence treatment have become our pharmacological tools, nicotine replacement therapies, bupropion, varenicline, or Chantix. And our advances in the neuroscience of nicotine and addiction, and nicotine addiction, and the relationship between nicotine addiction and mental health conditions has helped to elucidate and inform the advancement of treatments for this very, very important population of tobacco users. And it is no accident that we see a much higher prevalence of tobacco use in individuals with mental health conditions. And one of the contributing factors is the neurobiology of nicotine. As we are understanding more of the reinforcing effects of nicotine and the mesolimbic dopamine pathway, just as with other substances of use and abuse. The role of nicotine and the nicotinic cholinergic transmitter system in cognitive processes such as attention and working memory in locations in the brain in the hippocampal and prefrontal cortex that may account for the basis of increased prevalence of smoking in mental health conditions such as schizophrenia. And then we see the reinforcing aspects in the role of nicotine in the reward systems in the brain, affecting affective symptoms and the regulation of these affective systems, such as in the serotonin transmitter systems. So all these aspects of the neuroscience of addiction, and specifically of nicotine and the processes of nicotine release and transmission throughout the system in the brain, has provided a further basis for our development of both the pharmacotherapies and overall treatment of nicotine dependence in mental health condition populations. So based on the recent work with smokers with the diagnosis of schizophrenia, we've learned, for example, that treatments tailored for smokers with schizophrenia have a similar efficacy level as standard programs. In other words, the evidence-based approaches that work with the general population with the right form of tailoring can work just as well with individuals with schizophrenia. An important side finding in some of the studies on the use of bupropion and nicotine replacement with smokers with schizophrenia is that those individuals with atypical antipsychotic medications tended to do better, had higher cessation rates. And so this discovery, while still not quite fully understood, provides another important cue to look at the neuroscientific basis of these medications and effective treatments with this particular population of smokers. Bupropion has stood out as an effective tool, effective medication for smoking cessation, and also has been found actually to decrease the negative symptoms of schizophrenia, so having another benefit along with facilitation of smoking cessation. And varenicline or Chantix has been shown to, in clinical trials, not to worsen clinical symptoms to a greater degree than even placebo comparison medications. And there's been a trend toward improved cognitive function, at least in 1 or 2 studies. One important finding has been that more intensive and extended durations of treatment, both on the pharmacological side as well as the psychosocial counseling side, may be required, and in individuals with tobacco users with mental health conditions. And this is something, a theme we'll see over and over again. Now, until recently, by and large, most of the studies on tobacco use cessation until the last 15 or so years has really focused on the general population and unfortunately excluded individuals with mental health conditions. These are both, in the pharmacological side, is the interventions that combine pharmacotherapies with counseling. And the 2008 Public Health Service guidelines really strongly recommended increased efforts to really address this health disparity and the tremendous needs, thinking again, focusing on the fact that almost half of all cigarettes smoked are smoked by individuals with mental health conditions. And so it's been found that smokers with mental health conditions may tend to have more severe nicotine addiction. And what does this mean? There are simple ways of addressing or assessing level of addiction, level of dependence, such as asking the question, how soon after you wake up in the morning do you smoke your first cigarette? And those that generally answer within 30 minutes are going to be usually more heavily nicotine addicted, and may require more intensive treatment, both in terms of medications as well as counseling interventions. Smokers with mental health conditions do not need to be totally free of mental health symptoms to quit smoking. But given their more severe nicotine addiction, nicotine dependence, there's been an emphasis and a need for preparing these individuals to cope with the symptoms of nicotine withdrawal, which might tend to be stronger in these smokers attempting to quit. And there may be need for combinations of medications, which in the general population of smokers have been found to be helpful, such as combinations of bupropion and nicotine replacement therapies, or higher doses and longer duration of treatment, where traditional treatments might extend for 12 weeks, for example, doubling that time, and even in some cases there have been medications extended for a period of over a year. Of course, as other forms of addiction, nicotine dependence is a chronic relapsing disease, so one cannot just focus on one episode or one quit attempt, but it's an ongoing cycle. And with individuals, another recommendation has been that they should be offered realistic steps such as increasing their readiness to quit, a focus on the motivational aspects of the counseling, and even if necessary, a number of mini quit episodes before the goal of total abstinence is achieved. So in many cases it can be a longer term process and requiring more intensive interventions both on the medication as well as the counseling side. And a very important part of these interventions, it has to do with integrating tobacco treatment into the treatment settings. I was involved with a VA multi-site study focused on veterans with post-traumatic stress disorder who were tobacco users, and a randomized controlled trial in which an integrated care approach where the tobacco use cessation counseling was integrated in a part of and included with the trauma-focused therapy in these PTSD clinics, compared to usual care, which is referral to VA smoking cessation clinics, which also have very strong evidence-based pharmacotherapies and counseling available. But the integrated care group, the success rate doubled prolonged abstinence compared to referral to smoking cessation clinic. And the value of integrating treatments as part of overall wellness programs, recovery programs in specialty behavioral health as well as integrated care medical homes has really been a theme that has run through the studies in this area. So as far as some of the recommendations that have come out of the recent research on smokers with mental health conditions, there has been evidence for the efficacy of nicotine replacement therapy products, limited literature but growing literature, and certainly this is an option. The strongest evidence has been for the medication bupropion, which is another evidence-based medication in the general population of smokers and seems to be very helpful in individuals with serious mental illness. Evidence for varenicline, again limited but still promising, and risks around self-harm and suicide, the indications for carefully monitoring these serious psychiatric side effects. There's recent data, and including a recent large randomized controlled trial called the EAGLE study that was just released, that really shows that varenicline is no more risky than other medications and even placebos when compared in this randomized controlled trial. So some of the concerns have been reduced about some of the side effects associated with varenicline, which is the most powerful medication for smoking cessation across the board. The importance of assessing for nicotine dependence, as I mentioned before, has been highly recommended as a way of predicting whether a smoker will experience nicotine withdrawal and how strong those withdrawal symptoms will be, whether it be the cravings for tobacco use, irritability, insomnia, other nicotine withdrawal symptoms, and the importance of both pharmacotherapy and counseling in preparing the individual to cope with those withdrawal symptoms. And finally, that patients should be provided with behavioral and psychosocial support to help stop smoking. Dr. Satcher talked about the importance of physical activity, and this has been strongly advised as an important health behavior to integrate in tobacco use cessation treatments, and peer support as a promising resource in specialty behavioral health programs. Continuing recommendations, the 5 A's framework, which has been such a core element in the clinical practice guidelines across the board, are strongly encouraged. The importance of continuing to ask, to advise the patient to quit smoking is the most important thing they can do about their health. And we talked about the 25 years of reduced lifespan for individuals with mental health conditions, and tobacco being at the top of the list of contributing to that reduced lifespan. For patients unwilling to quit, the story is not over. This is where the motivational interventions and the counseling interventions revolving the 5 R's, focusing on the relevance of quitting smoking to their valued activities, the risks of continuing to smoke, the rewards involved, and the benefits of quitting, the roadblocks, and repeating these messages for those who are not yet ready to quit. Again, the story is not over for those individuals. And again, since quitting smoking can lead to alterations in the psychotropic medication levels, the importance of monitoring these levels for at least 6 months after the individual has quit smoking, and monitoring weight and metabolic markers as well as mental health symptoms. These are all outcomes that are important to continue to monitor, whether in integrated care settings or in the specialty behavioral health settings. And most importantly, smoking cessation should be given utmost priority in clinical practice, and all members of multidisciplinary teams in medical homes or in specialty mental health programs should have a role in this. Here is a list of some of the successful programs, some of the experts in the field who are doing the research, providing the services, providing the training for providers for smoking cessation treatments, again, pharmacological treatments and counseling treatments and combinations for individuals with a variety of mental health conditions. Tony George at the University of Toronto, the work he's been doing with pharmacotherapies for smokers with schizophrenia. Jeannie Beckham at Duke University and the Durham VA, focusing on veteran smokers with post-traumatic stress disorder. The Choices program in New Jersey, which is more of a consumer support network for improving the condition by ending smoking, focusing on smoking cessation. The Tobacco Recovery Across the Continuum, or TRACK program at Case Western. So a number of programs that are incorporating these pharmacotherapies and counseling therapies into wellness programs, into behavioral health, but also integrated primary care, where we have behavioral health consultants available to provide additional counseling and support in the long haul for individuals who really need this for relapse prevention purposes, as well as focusing on motivation to quit. Technological advances are happening across various healthcare systems, whether in VA or other healthcare systems and in medical homes. The use of quit lines and Stay Quit Coach apps, text messaging. These are areas that we're exploring in tobacco use populations with mental health conditions in the VA, but in other healthcare systems as well, and should be a very important part of advancing, increasing access to these very important evidence-based treatments that are so much needed by individual smokers with mental health conditions. And finally, I just want to recommend to you probably a site that most of you are very familiar with, the SAMHSA HRSA Center for Integrated Health Solutions, that has a special section on tobacco use cessation resources, training, education, literature, and it's a wonderful resource, and listing of successful programs as well that I highly recommend to you as well. So that is my final slide and concludes my comments, and so I'll turn the program back over to Brian.
Thank you. Thank you very much. Should be able to hear me clearly now. Just wanted to get to a couple of questions. I want everyone to know also, this is important to know, that you will all be, this presentation will be posted online, so you're able to download this presentation. So you'll have the PowerPoints, and you'll also have an archived version of this presentation for those who would like to watch it again or share it with someone else. A couple of questions that I have for both Dr. Thatcher and Dr. Carmody. The first question is from Jamie, and I think this one is directed to Dr. Thatcher. In the WHO report, why was it estimated that deaths would increase?
Well, I think it was due to the fact that we had not yet implemented a lot of the interventions. And there was no indication at that time that there would be a World Health Organization treaty. This was the first time that WHO had a treaty meeting of this kind, of any kind. And so I don't think intervention globally were in sight in 1999. And they developed later, which is great, which is the fact that the more we understood that something could be done, given the dramatic decline or decrease in smoking in this country, then I think the World Health Organization felt that it should be a global effort. So I think the predictions that were shown were based on things not changing globally the way they have.
Thank you, Doc. Next question is from Denise. How much is known about the interaction between psychotropic drugs and the FDA-approved tobacco cessation medication?
Is that for Dr. Carmody?
Yes, a fair amount, actually, in terms of the impact on the metabolism and the enzyme processes involved, and so this is why and this is including the nicotine replacement products, and bupropion and varenicline. But much more is known about the impact of nicotine and nicotine cessation than about the impact of these other medications in terms of the interactions with other psychotropic medications.
Thank you, Dr. Carmody. Another question from Denise is, since nicotine is, since nicotine is implicated in the neuroscience of addiction, what role, if any, do e-cigs play in tobacco cessation for those with mental illness?
That is a great question, and it is something that has been explored. There, as you probably know, a great deal of controversy around e-cigarettes. In the VA, the official guideline is for us really not to encourage use of e-cigarettes. When you look individual, are the health effects of using e-cigarettes greater or less than combustible tobacco? One would think that the combustible tobacco is where the most risk and the carcinogenic effects of tobacco use are located. At the same time, there's still so much we don't know about the other aspects of the chemistry involved in the vaping and in these e-cigarette products. And the evidence is mixed at best. Well, the evidence is pretty strong that among children and adolescents that there does seem to be a gateway effect of e-cigarettes moving to combustible forms of tobacco use. And adults, in terms of a cessation method, the evidence is mixed, if not on the negative side, in terms of its impact on tobacco use in terms of the combustible forms of tobacco use. So it's still, this is a very interesting area, and one that is being looked at in the literature on tobacco use cessation in mental health and populations, individual smokers with mental health conditions. And it's still something being debated, and I wish I had more of a clear answer for you. There are some plus minuses in this, as looking at this as an alternative to, as a method for cessation.
Thank you, Dr. Carmody. Oh, another question for you, Dr. Carmody, is the FDA likely to take the BBW off of Chantix?
I read somewhere recently that is in the works, if not it already has been done. but if not, it's soon to be. Again, I would recommend you're taking a look at the recent publications that have just come out, I believe in Lancet, on the Eagles randomized controlled trial, and Pfizer was one of the funding contributors, and a number of countries involved. It was a multinational global study of some 8,000 smokers that compared neuropsychiatric side effects across nicotine medication products, smoking cessation medication products, and including placebos, and really showed showed evidence that there was no increased risk associated with varenicline compared to other smoking cessation medications, and including placebo. So, but the FDA, if it hasn't happened already, I recall seeing that somewhere, that the black box warning is in the process of being removed.
Great. And this question is for both speakers. Can you talk about the treatment that has been integrated into safety net mental health centers, where one-on-one or group sessions are provided?
Well, I'll just briefly say I think that all indications are that certainly integrated care is superior in terms of outcome. And I think it's because, number one, there's going to be more access and more interaction if a person is coming for primary care, for example, as we provide it in a community health center, and we work with 11 community health centers right now. But in that setting where with the appropriate training, you do have teams of people who, number one, communicate among each other about the patient's needs, and then bring the best interventions to bear in meeting those patients' needs. Patients certainly seem to be much more comfortable with that approach, and certainly more comfortable at not having to go somewhere else to get one aspect of their care. So our experience is that integrated care is superior. I think the studies show that too when it comes to smoking cessation.
And I'd like to add and emphasize just what Dr. Satcher was saying. The key word is team. As we have these expanded medical homes, and in VA we call them patient-allied care teams, in the primary care setting, as well as other integrated care settings, we have increased access where traditionally we thought of counseling as a 3-minute talk of advice with smokers with mental health conditions. We're seeing that it's probably going to take more than that, and we used to define intensity as something 30 to 60 minutes of counseling was high intensity, and in busy primary care settings, if we're just talking about a single provider, yes, that is a lot of time. With the normal visit, 15 to 20 minutes, but when we're talking about teams that include other people, including peer support people who are willing to do are able to do some health coaching, for example, and behavioral health consultants and other members of the team integrated into that setting, that we can do more of the group work that really is beneficial for individuals with mental health conditions attempting to quit smoking, along with monitoring the medications, the impact on their psychotropic medications, and all of that.
Did we lose Rich?
We have a question. So for both Dr. Carmody and Dr. Satcher.
Sorry. Can you?
What are your thoughts?
Richard is back.
Okay, I'm back on. I'm sorry about that. Sorry about that technical issue. I had a question from Sean. Have any coping and problem-solving or mindfulness and relaxation components been rigorously tested among smokers with mental health conditions to simultaneously reduce tobacco use and mental health issues? Were you able to get that question?
I'm not aware.
Great question, and these are very strong evidence-based approaches that, and for example, with mindfulness, we're seeing evidence now of its help with post-traumatic stress disorder across a number of disorders, mental health conditions, and I'm not aware of clinical trials that have rigorously tested this in terms of its dual impact of symptoms of specific mental health conditions and tobacco use. I'm aware of some applications in general populations of smokers within the framework of acceptance and commitment therapy, for example, that includes a mindfulness piece to it, but not aware of again, it's the rigorous testing of the approaches you're suggesting.
Okay, Grace asks, do you think that people living with mental illness should disclose this if they call or use a quit line? And she also added, I'm not sure if this is asked or it sounds like counseling should be tailored in this population. So I think that oh, go ahead.
I'm not sure. You're saying if they call about quitting or if they call? I would think that. Okay. I think in order to get optimal intervention, the person on the other end of the line would need to know what the patient is dealing with, if I understand the question correctly.
I think that was the question.
Yes, and just to follow up on what Dr. Satcher is saying, it's I think disclosure of a mental health condition, there may not be a question that's asked, well, do you have a mental health condition, but it's more in terms of discussions of the triggers, for example, to the urge to smoke, for example, where the discussion of those triggers, for example, end up including mood changes and so forth that may be related to a mental health condition that becomes part of the counseling and problem solving and treatment plan and the quit plan for the individual on a quit line. But the evidence-based aspects of these quit lines in terms of having a special outreach to really address the needs of smokers with mental health conditions, I think that's a great question, and it's done in that way in terms of the content of the counseling and specific aspects of the quit plan, and such as what I just showed the example around the triggers.
Okay, Chris asks, you mentioned telehealth, for example, Skyping, FaceTiming. Do you know if Medicaid or Medicare or private insurers will reimburse counselors through telehealth?
Well, I think certainly the answer is yes. In most plans now, the telehealth interventions have been tested, and so more and more plans are covering telehealth intervention if they're in a position to evaluate them.
Okay, last couple of questions. Ruth asks, can they lead me to specific case studies or clinical models for integrating care, growing the team-based care? And she's looking at a VHA 1.
Well, one of the first studies from the VA, of course, of integrated care, if I understood your question correctly, was Ben Drust and colleagues showed the efficacy of integrated care. And that's certainly a good place to start. There have been many studies, I guess, since then, and a lot of studies in the VA, a lot of studies of post-traumatic stress disorders and interventions. So I think Dr. Carmody has been involved in some of those, so I'll let him say more about that.
The VA is Center for Integrated Care Research and Clinical Practice has done a lot of work in this area, and there are a number of investigators. Laura Ray, W-R-A-Y, is the name of one individual, and there are a number of very talented, hard-working experts in this field working out of that center in upper New York State, and as well as the other centers within the VA. Outside the VA, I'm less familiar with the work being done. Again, in VA, I mentioned the study that focused on tobacco use cessation in PTSD clinics in the VA. So there's the full integrated care model, and then there's integration of tobacco use cessation into that integrated care model within the context of wellness programs, for example, within the context of expanded medical homes, so those are some examples that I can think of.
Okay. Sheena asks, what are your thoughts on fresh air breaks in substance abuse facilities that are not tobacco-free? What do you suggest as a positive replacement?
Well, my thoughts are very negative about exposing people to smoke. I remember, it was a long time ago, I guess now, but supporting teachers in inner city schools, and I took the kids out into the hallway. This was before I became CDC director, and smelled tobacco smoke and discovered that the teachers took a break to smoke, and yet the vacuum in the room was not working, so the kids were being exposed to tobacco smoke. So, I think when it comes to exposing people to nicotine, it should be a no-no now. California was the first state to outlaw smoking in public places. And I know that over half of states have now passed such legislation. So I think our whole attitude toward exposing people to smokes, people who don't smoke, exposing them to tobacco smoke has changed over the years, and rightfully so. It is not something that's tolerated for any group.
The one alternative that immediately comes to mind is for how to spend time during a break is something that I see happening around me here at the San Francisco VA is among providers as well as our consumers is the activity of walking, for example. And but I'm also aware here's where another health disparity exists in terms of neighborhoods of poverty and neighborhoods where walking, the neighborhood is not conducive to going outside to walk, and the air is not fresh. It's urban air that, and actually Neil Benowitz here in San Francisco, who's an expert on carbon monoxide monitoring of the metabolism of nicotine, has been doing studies on the environment, and we use CO as a measure of smoking cessation, but when you measure it in urban air situation, we have to kind of modify our critical levels because of the nature of air quality in general. But so there are a number of topics in terms of health disparities this brings us into, but it gets back to an overall wellness approach and cultural change for our behavioral health programs as well as integrated care, and including our substance use disorder programs as well.
Okay, this will be our last question.
Just a lot of the apartment buildings in urban communities, nobody may smoke in a family, and yet, because of the way the apartment buildings are built, children are exposed to tobacco, and especially children with asthma or children who have the onset of asthma because of such exposure.
Thanks for that point, Dr. Thatcher. Last question is from Candace. What would your recommendations be to engage physicians within inpatient psychiatric settings that are resistant to provide NRT and to enforce smoke-free grounds and environments? I can ask the question one more time, Dr. Thatcher, just so you can.
Yeah.
Well, let Dr. Carmody go ahead if he understands.
My thoughts about that. That is a great question and ongoing discussion about the best ways to address these forms of pushback, and it has to do with sitting down and having that opportunity to find out more about the reasons for that disinclination, or again, getting back to some of the myths or consequences of taking those actions that might be perceived but not based on reality or evidence. Sometimes it has to be a brief elevator type talk of just a couple of minutes, but really it has to do with using the same principles of motivational interviewing with our colleagues, in the sense of really finding out what the source of the resistance, how that conflicts with their values. Is a concern around the acuity of the patients or some other issue that is getting in the way of their moving ahead with those proposals.
Okay. Well, thank you so much to both Dr. Thatcher and Dr. Carmody for a very lively and informative discussion. Again, this is the second part of a three-part series that we're doing in partnership with the CDC. You could follow us on Twitter at PriCareMatters. You could also visit our website at primarycarematters.org. If you registered for this webinar, we will be sending you a link to the archived webinar. We will also be sending you a link if you're interested in getting credit for this event. For the live event, you're able to get credit. So we'll be sending that link out to you immediately after. Again, thank you so much for your participation, Dr. Carmody and Dr. Thatcher, and for all of you who joined. Thank you from the National Center for Primary Care at Morehouse